Okay. Well, good evening, everybody, and thank you for taking the time to join us for a presentation on an FDA-approved treatment for diabetic peripheral neuropathy pain. My name is Jennifer, and I'm a therapy awareness consultant with Medtronic, and this program is co-hosted by both Medtronic and Healthy You Clinics. We are very pleased to have with us this evening Dr. Alexander Didick, who is the Director of Pain Medicine for Healthy You. And this is actually his second webinar, so he's and actually has a couple patients from the last webinar that did really well. So we're very pleased to have him with us here tonight. But just a few housekeeping tips before we get started. I did mention we are recording this. We also have closed captioning for anybody that might find that useful. And all lines have been placed on mute. We just want to prevent any background noise so that everybody can be in full attention mode. And then at the end, we will have a Q&A. So if you do have any questions, feel free to go ahead and type them in the Q&A, and we will make sure we get to those before we close out the program. So without any further ado, I will pass over the mic.
Thank you, Jennifer.
You're welcome.
And hello to everyone on the webinar this evening. I'm Alexander Didick. Some of you I've gotten a chance to talk to before who are on this webinar. Those who I have not, hopefully this is informative and we can answer some of your questions as well. So I'm an interventional pain management physician as well as a sports medicine physician, kind of born and raised here in Phoenix, Arizona. Outside of doing some of my training, been mostly living in Phoenix. I see patients across the valley, East Valley, West Valley, and in North Phoenix at my company at Healthy You Clinics, and I've been there for going on close to 2 years at this point. Happy to get to talk to you guys a little bit about spinal cord stimulation and specifically for diabetic peripheral neuropathy tonight. It's a wonderful therapy, and we'll go through it so you'll have a really good grasp of what neuropathy is, as well as what therapy we're talking about and the effectiveness of that therapy. And I'm going to scroll a little bit now. Okay, good. My slide control is working. I can actually use it. So we'll talk about a little bit about diabetic foot pain, as well as the management of how do we kind of take care of the pain that's associated with it. Then we're going to go into spinal cord stimulation, and then we'll have a Q&A, kind of as we mentioned at the end of the webinar as well. So patients with diabetic foot pain will come in our office and start explaining to us, what are my symptoms? What am I feeling, right? So these are some examples around the screen, but I'll share with some more. So if a patient's coming in and saying, I have sharp pain that can kind of leave me kind of breathless. Another example here saying, hey, I've got like a feeling like I've got a hot poker on my feet, okay? Or I feel like I've been sitting in an ice bath and my feet are becoming very, very painful. The pain that's getting worse at night because I'm paying attention to it at the end of the day. One of my favorite examples a patient once told me is saying, it feels like, when your foot falls asleep, but it never wakes up. These are very problematic, right? Because we a lot of times have a really good understanding of, let's say, pain if we kind of stubbed our toe and it was painful and then it kind of resides. But with diabetic foot pain, we're talking about pain that isn't necessarily improving. It's pain that's kind of there every single day. And it doesn't necessarily get better or worse. It's kind of persistent, and that persistence can have a huge impact on our quality of life. And that pain can really, basically have an impact that is affecting our day in and day out repertoire of our life. It also affects our work. It affects every aspect of what makes us who we are. And I think that is why we want to talk about these kind of therapies, because if we have a really significant impact on our quality of life, as well as our function, our life is impacted in every aspect. And I think that is why diabetic foot pain becomes such a huge concern kind of when it comes to treating pain. So diabetic foot pain goes by a few different names. So painful diabetic neuropathy, we might use a shorthand tonight calling it DPN. We call it a debilitating and progressive neurological disorder. It's affecting nerves because diabetes affects our blood vessels as well as our nerves. And when diabetes, either if it's uncontrolled or controlled, even pre-diabetics can have diabetic foot pain. And this ultimately results in pain that we try to treat with various different mechanisms. One is kind of getting our diabetes and blood sugar control under good management. but also we use kind of medications, and medications may be effective, may not be effective. They also have lots of kind of side effects. And one of the issues that we run into with medications is often they may have lack of tolerance, they may have interactions with other medications, they may be contraindicated, meaning we can't use them because of someone's history, or they may be just overall ineffective, or may be requiring to be using multiple medications. And usually, when patients are coming to see us, and then we have conversations with diabetic for basically spinal cord stimulation for diabetic foot pain, we're usually talking about patients who've tried multiple medications, and they're looking for something that may have better efficacy, meaning that works much better, as well as a permanent treatment solution. So spinal cord stimulation, this is one of our kind of pride and true ways of treating kind of pain and pain management. Spinal cord stimulation is proven it's a non-opiate option. It's FDA approved way of kind of treating diabetic foot pain. We also use this for multitude of different kind of pain disorders, but today we're talking mostly about diabetic foot pain, so we're going to focus on that. Stimulation is delivered basically through a neurostimulator. So think of this kind of like a pacemaker that would be kind of inserted underneath someone's skin and kind of laying along the area of the spinal cord that interprets for foot pain, essentially. So an impulse will travel from the device to the spine over a thin insulated wire. These are called leads, and those leads deliver an electronic impulse to the area in your spine. One way of really kind of I describe this to patients is saying we don't interpret pain until it reaches the level of our brain. So let's say we have diabetic foot pain, and that pain is, as you would guess, in our feet. That signal needs to travel from our feet up our legs to our spinal cord, and from the spinal cord, it goes to the brain. And if we can block that pain signal at the level of the spinal cord, our body never experiences that pain or feels that pain. That's what's a wonderful tool about spinal cord stimulation. There's multiple different types of spinal cord stimulation, but one of the most amazing things about it in today's world is that we can just block the pain signal. And by blocking the pain signal, we are talking about often the absence or significantly reducing the severity of pain. Patients deserve an opportunity to experience spinal cord stimulation if they have painful diabetic peripheral neuropathy. This is because it's such a valuable treatment option. It has great efficacy in its use, meaning that patients are very likely to have a successful trial and a successful implantation. And this has been studied long-term over many years. We often talk about saying, hey, like, why don't we reach for this option first? Well, a lot of times we're dealing with insurance companies or having these kind of conversations, but if you could reach for this first, I would. I think this is such a wonderful modality for patients, essentially because of how useful and life-changing this can be. Earlier we talk about saying, hey, like, why are we moving forward? Why are we having conversations about spinal cord stimulation? Why are we talking about medications? Well, a lot of times it's because we have such a profound impact on our quality of life. It's affecting every aspect of how we do things. And so we need a solution that can really help solve that problem. And I think spinal cord stimulation is a wonderful tool to do that. So what are our goals? What are we trying to do? So if we're treating this, obviously we're trying to treat someone's pain, right? I think that is kind of the first and foremost aspect. And through treating pain, because pain can be kind of all consuming and be our focus, a lot of times that also allows us to focus on other things, right? If pain isn't first and foremost in the front view mirror of our life, we can manage complications better, right? If we're walking more, maybe our sugars are getting even kind of better control. Maybe other aspects of our health are improving, right? We can slow the progression of disease if we're managing and taking care of ourselves better. There's an old joke in kind of medicine is if we limit our stress, if we take care of ourselves, we get a full night's sleep, we're exercising, we're moving, we're doing things we're supposed to, our medical basically problems will be reduced significantly. And when pain becomes such a large kind of component of our life, as it is in diabetic foot pain, we have to intervene in some way to really help us improve our quality of life. So one of the things I like to explain to patients for diabetic foot pain as well as for chronic back pain is spinal cord stimulation is one of those things that we can kind of rent before we can buy. That's kind of our ongoing joke. So spinal cord stimulation allows us to do a trial period before we do a permanent implant. And a trial is just that. It's a trial period. If someone's never been seen a doctor for spinal cord stimulation or any injections or things like that, we often talk to them about the steps that go into spinal cord stimulation. And the trial is a little bit of background noise in my screen. Sorry for that. Spinal cord stimulation trial is essentially we bring you into our office, and under an X-ray camera, we guide these leads that we mentioned before, these electrodes essentially that kind of go from the outside skin down into the space between the bones in the vertebrae to allow us to get near to where the spinal cord is. And we lay those leads on top of the spinal cord in an area called the dorsal column. And there's different areas of the spinal cord that interpret pain for the back, the foot, a bunch of different areas on our body. We really are targeting the area that goes to the feet. We do that, and then those leads stay external to the body. I mean, they're taped down with an external battery, and then the device is programmed, again, similar to a pacemaker, that allows you to assess how much pain relief someone is getting during the course of the trial. You're in constant contact with our office as well as your representative during this period. During the trial, this can last up to 10 days. It's often a 7-day trial. So we'll do a trial, let's say, on a Monday, and those leads kind of stay in place for about a week. And we're seeing during that time how much pain relief that we're getting. Vast majority of patients are having successful trials. As you can kind of see on the stat on the right, 2 clinical trials, over 80% of patients are saying they're having a successful trial. This is often at least 50% pain relief, but a lot of times we're looking at 80, 90% pain relief, which is really significant. It's clinically significant and has a huge impact on our quality of life. Then when we come in at the end of the trial, those leads are kind of removed, and we kind of talk about the end result, essentially. And when the trial is successful, which it often is, we talk about moving forward with a implant, and we'll talk about that as well. So just to review again, these slides sometimes give us a little bit better of information than me just kind of explaining to it. On the figure on the right, we're kind of saying, okay, this is an external neurostimulator. So this is basically almost an external battery, and it's connected to these temporary lead wires that get tunneled underneath the skin, as I mentioned, and they're laying on top of the spinal cord. This all gets kind of taped down onto your back, and then we end up kind of programming this with a patient therapy manager, which kind of looks like a cell phone, essentially. There's different settings, there's different programs, and those programming, as I was mentioning before, are able to target the nerves that sense pain. That's where the dorsal column is. And it's able to block the pain signal that's going from your feet up to the spinal cord so that that signal is not being interpreted at the level of the brain. A wonderful technology, and it's amazing that it exists, truly. Also kind of mentioning on here the steps that go into a trial. Obviously, a patient needs to have diabetic peripheral neuropathy. As I mentioned before, we've often kind of gone through medication management and had conversations with that, and generally failure at that point. Other steps that we often go into is requirement for psychological clearance to help determine who's a good candidate. Vast majority of patients aren't good candidates for it, but we do have patients who say, hey, maybe we need to kind of work on a few things before we move towards spinal cord stimulation. For example, if someone has uncontrolled depression or anxiety, we want to treat those underlying comorbidities or other medical problems and optimize patients before we move forward with the trial. We often get an MRI as well to make sure that the electrodes will fit in the correct space where we're going to be tunneling those leads to. So essentially, we'll get some imaging prior to the spinal cord stimulation trial, as well as do psychological clearance beforehand too. And we go through all of this long before we actually are the day of the trial. The trial process, very straightforward, very simple. Kind of, we already went through all of this, but very useful. The one thing that I'll kind of also add to this is the vast majority of these trials we can get done in under 30 minutes. Sometimes it takes a little bit longer, just depending on someone's anatomy, but from start to end time, it's pretty straightforward. And as I mentioned, most of these stay in for about a week. Sometimes we'll do it a little bit shorter, depending on the patient's schedule, but I usually like to leave the leads in for about a week so that someone has a weekend and able to do normal activities during that time period as much as possible. So our goals, as we mentioned, are paramount when it comes to spinal cord stimulation. And again, with diabetic peripheral neuropathy, it's always there. You know, that's a difference between, let's say, diabetic foot pain and some other problems that we run into with chronic pain. Let's say if someone had chronic back pain, it might be positional. It might be there's certain activities that really kind of set someone off. But often with diabetic foot pain, it's always there. It's kind of this kind of constant nagging that's kind of going on. And what happens is we become subconsciously aware of the fact that we're in pain. And so we do the activities to actively avoid those provokers of pain. So if standing makes it worse, we don't stand as much, right? So maybe a goal for us is to be able to stand longer. Or maybe we have trouble sleeping because our feet really bother us while we're sleeping. And if wakes us up from night or makes it harder for us to go to bed. So maybe the goal for the trial is saying, hey, I want to be able to sleep for a longer period of time. And that's important with us too. So we have to set goals and then say, are we achieving those goals? We want to make those realistic goals. Patients are high responders. This is a wonderful therapy, but at the same time, what we're looking for is clinical significance, not just a number. We want to say, how is this affecting me day in and day out? Then once we determine, say, hey, I had a successful trial, we often are kind of given a number. It was 85% effective. Wonderful. I was able to walk twice as much. Wonderful. This is really, really useful. Then we talk about moving forward with an implantation. And implantation is similar to the trial, except it's permanent. So the difference between the trial and the implant is the leads are buried underneath the skin and the neurostimulator after making a small incision is inserted underneath the skin, similar to a pacemaker. The neurostimulator is very small. It's about a little bit smaller than a Tic Tac and about half of its width. There's both rechargeable and non-rechargeable options. So rechargeable is what you would expect. You charge it when the battery is running low versus a non-rechargeable battery that does not have to be charged and just is a slightly larger, but doesn't have to worry about the process of recharging, essentially. Ultimately, we are trying to reproduce the exact conditions of the trial when we're doing an implant. The leads are going to the exact same location as they did in the trial. And then the only difference is we are, again, burying those leads underneath the skin with a small incision to anchor those leads in place, as well as making a second incision to have the neurostimulator be implanted underneath the skin as well. This is typically located in someone's kind of flank or upper buttock kind of region. That's where typically the battery or neurostimulator is placed. We do typically these at the surgery center. The surgery center, patients get there about an hour before the procedure. Generally, an implant, again, will take about an hour. Sometimes it can be a little longer just based off someone's anatomy, but essentially we do the implant and then we schedule a follow-up. Patients go home the same day. They may need a little bit of a post-operative kind of pain medicine for a day or two, but generally very, very well tolerated. And then we schedule our follow-up. We're making sure everything is healing well. And at that point, we turn the device on and then we go about living your life. So there are many unique benefits for spinal cord stimulation, but with Medtronic, I think one of the most wonderful things about it is just the long-term recognition as well as experience that they have in the field with over 40 years of basically technology that's been utilized. And I think this is important. They're kind of the first and foremost company that we think of when we think about spinal cord stimulation. I think one of the other kind of reasons why Medtronic's devices work so well for patients as well as providers is they're largely 100% MRI compatible. And I think that's important because patients often need MRIs for one reason or another. When we're dealing with patients with diabetes, as we are with diabetic foot pain, we also think about things like infection. And so there is another envelope essentially that kind of helps that we kind of place our neurostimulator within called Tyrex that also helps reduce the risk of infection. This is all kind of in combination of saying, hey, if I'm going to move forward with spinal cord stimulation for diabetic peripheral neuropathy, who should I choose? And I often say, hey, like Medtronic has a wonderful reputation. I think the device works. I love working with their staff. I love the options that this gives our patients moving forward. This is just a little bit of a Tyrex. Okay, so patients will ask me, okay, that sounds great. Tell me about the risk related to this. So for both a trial as well as an implant, we say anytime we break someone's skin, there's a small risk of infection. There's a small risk of bleeding. We stop patients' anticoagulants, so any kind of blood thinner, prior to reduce that risk. Similar, if someone's a diabetic, we want to optimize their blood sugar. We want them to have sugars that are in the normal range to decrease our risk for infection. Similar, we want to be able to say, hey, like we gave our patients every opportunity to heal properly. So if someone's a smoker, we want them to stop smoking. Also, just from the procedure itself, we're getting really close to where the nerves live. So this is why we use an X-ray camera, and this is why we take our time to make sure we're in the right spot. We try to reduce the risk as much as possible, and it's very low risk for anything like a nerve injury or a post-procedural headache called a dural puncture. But these are risks, and these are things that we discuss as well. Separate from that, we always say, hey, what if it doesn't work? That's okay. The vast majority of people, these trials and implants are successful, but I have to say, I can't guarantee something is going to be successful, but we do everything in our power to make it successful. Separate from that, if the leads move or migrate, this also can happen. So it can kind of malfunction from that as well. Again, we troubleshoot these things from both the front, saying, hey, we're just talking about this on trial, or if I'm following up with you 12 months or 2 years after an implant, we're talking about these things. Okay, so before we get to the Q&A, we'll have a couple things that are just kind of saying, what are some common questions? So we can answer these too. So maybe this will answer some questions for the Q&A side of this. So the neurostimulator, as I mentioned, is quite small. It's smaller than a box of Tic Tacs, and it's about half the width, essentially. So if you look at the bottom of the screen, they have the size of the Intellis, that's a quarter. And then kind of looking at it on kind of long axis, or just basically looking at it from the side, it is quite thin. The Vance is a little bit thicker. I would say it's about the thickness of a Tic Tac box, but it's a non-rechargeable device. And that incision is a 4 centimeter. It's very small, and we kind of place that on either side of where a patient would have more comfort. So we usually kind of basically put the neurostimulator battery on the opposite side of, let's say, where someone wants to sleep. Or if there's a preferred side saying, hey, I wear my toolkit on this side of my body, I'd like to have it on the other side too. So we kind of place it depending on what the patient's preference would be. So will spinal cord stimulation therapy eliminate my diabetic peripheral neuropathy pain? I think elimination is the goal, right? But it's also saying, am I guaranteeing that we can eliminate someone's pain? I like to think that most patients have very significant clinical significance, meaning it's impacting your life in a meaningful way. Most patients are very happy that they've gone through this process of both a trial and an implant. And I think that's part of the reason why we do a trial, right? We want patients to experience significant pain relief. Because if we've lived in pain for a very long period of time, we kind of forget what it's like to live without pain. Our body is very, very adaptive. And in some ways, that's a good thing, right? It's a good thing that we can still kind of go to work and still kind of be with our family, but our quality of life can suffer quite a lot. And so when we do a trial and it's very successful, it can be very jarring because we say, oh my God, I've lived so long with pain and now I don't have pain. And so that's what we're looking for when we're doing spinal cord stimulation. What are the risks I need to consider? We talked about that a little bit in terms of infection, lead movement. Also can mention there could be some pain at implant location, which I don't see very much, but it can happen. Loss of efficacy, meaning that over time the stimulator isn't working to the same extent that it was, maybe need to be reprogrammed, or again, as I mentioned, those leads can migrate, fracture, or break that we talk about as well. And this is why we follow up, right? So at the same time, we don't just say goodbye to you after we kind of implant a stimulator. We're following up with you on a regular basis. Where can we learn more? We can visit medtronic.com/dpnpain, be able to kind of talk more about this in further detail. You can click on, you can scan this QR code as well, or enter this address in your browser. So if we want to learn a little bit more, be able to keep track of some of these things, the Care Pro Guide app is a free app to navigate. It's basically our information about spinal cord stimulation. You can download that app if you'd like as well. As we mentioned at the top, there's multiple indications for spinal cord stimulation. Tonight's kind of talk is focused on diabetic peripheral neuropathy. Probably the most common reason why we do spinal cord stimulation is for what's called failed back syndrome, or basically patients who've had previous back surgery. But there's multiple different indications. So if you've had things like long-term herniated disc causing pain, we often see people for multiple reasons. I mean, it's not uncommon for me to see someone who is both diabetic peripheral neuropathy that's painful, as well as a history of ongoing chronic back pain. And those kind of mixed clinical pictures, we can address both of those at the same time while we're doing spinal cord stimulation. So we can address both the back pain someone's experiencing at the same time as trying to address their foot pain, and trying to get coverage with those leads to cover for the back and the feet at the same time. And that's a brief summary. Okay. Jennifer, do you want to click on this? This is a patient testimony. Jennifer, are we supposed to have sound? Oh, that is
Yes,
sound.
can you not hear the sound?
I cannot hear the sound, no.
Okay, let me see, because I changed control. Let's see. Okay, let's try it again.
Okay. There we go.
Good.
So
Okay.
in 2015, I started having pain in my low back, and the pain will go down my legs. And then it turned into numbness and tingling in my lower legs and feet. And we came to realize that part of the issue was diabetic peripheral neuropathy. My name is Farrah Stewart Tarver, and I live in Spring, Texas, a suburb of Houston, with my husband, kids, and I am a nurse by trade, a pediatric nurse. So the pain got to be where I would say it was a 10 of 10. I stopped working at several points. I was home in bed most of the time, sitting on a heating pad, pretty much feeling depressed because I felt like I worked so hard for my career, and there were things with my children that I was not able to do. I went to see numerous providers. I've done physical therapy, taken medication. I've had steroid injections, nerve blocks. You know, they really felt like they couldn't figure out what to do to help.
Hi, Stuart.
So they said, well, maybe you should see Dr. Patel. She's an interventional neurologist. You know, maybe if you see her, there's something that she can do to help you.
So what I told her is that, you know, Farrah, since you have optimized your oral medications, you've done your physical therapy, you've tried the creams, and you're still in a good amount of chronic pain here, and you're having this painful diabetic peripheral neuropathy, why don't we take the next step for spinal cord stimulation? So we took her to the surgery center, we did a spinal cord stimulator trial. She had a successful trial, which is great because it's like test driving a surgery without committing to the surgery. Do you feel? After the trial, Farrah did elect to undergo that surgery with me. So within a week or two, she was back to doing her normal walking, up and down stairs, groceries, all of those things.
I can go on walks. I mean, that in itself is a big deal because I hadn't been able to like get up and go to the park and go for a walk. So, you know, I can do that with my daughter now and just do different things with my kids that I had been unable to do for years. We love to travel. We try to travel frequently. I had to stop doing that for a while unless it was absolutely necessary. And now I've been able to go to I've gone to Vegas twice since I've had the simulator. We went to Hawaii, which was an 8-hour flight. So my outlook improved dramatically on, the future, because now in my head I'm thinking to myself, well, maybe I won't have to be in a wheelchair in 10 years when I'm in my early 50s.
For me to be able to see someone like Farah, who came to me almost really depressed, not knowing what her future would hold, reach a point of her life where she's so happy, so active, and really hopeful about the future. This is why I do what I do.
That's great. All right, everyone. We're going to be able to open up for a couple of questions as well, if anyone has questions tonight.
Yes, thank you everybody for attending. Hopefully you found that as informative as we all did, but we'd love to answer any additional questions you have. So if you have any questions, concerns, or anything you would just like to discuss, there is a Q&A at the bottom. Go ahead and type the questions in there and we will answer them one by one. And that Q&A should be right there at the bottom of your screen. I don't see anything coming in yet. Anything at all?
That's okay.
I think you did such a great job and you
explained it
covered
so
everything.
well. I know.
Oh, it looks like
Thank
we
you.
might have one. Oh, thank yous.
Well, I appreciate everyone tuning in tonight, truly.
Yeah, well, if we don't have any questions or if you guys think of anything later, we would love to follow up with you. There is a QR code that you can scan to get more information, and you can see on the top right side of the screen, there is information to call or schedule directly at Healthy U Clinic with Dr. Didick, and he would love to be able to discuss it with you and your condition personally. So I will actually reach out to everybody after this, and oh, let's see, we might have one question. I have spinal stenosis, would it help? Oh, are we frozen? Dr. Didick? Okay, can everybody hear me? It looks like we just lost Dr. Didick.
They lost me.
There we go.
I was literally sitting there, my screen went blank. And I was saying, what just happened? I had to look at my internet connection. So I was
Okay.
in the middle of that, but I think my answer was, long story short, you can't help pain that's associated with spinal stenosis as well.
Okay, perfect.
How often
Let's,
does the battery work? So depends on the battery. Okay, so if you have a permanent battery, we have batteries that can last. You're usually looking for at least kind of 5 years. If you're looking at a rechargeable, a lot of times you're getting kind of closer to 8 to 10 years, often. Good questions, Larry. Appreciate it.
We got another thank you.
Thank you. Thank you.
Okay, do we have any other questions? I don't see anything else coming in, but again, if you have any questions, don't hesitate to reach out to us. And we'd like to thank you so much, Dr. Didick, for your time and your presentation. You did an amazing job.
Appreciate it. Thank you so much. Have a wonderful night, everyone.
Thank you,
See you.
everybody. Have a good evening.